everyone. My name is Dr. Anas Namar, and today's topic is very important. It's regarding pregnancy loss and abortions. Now, what is the definition of pregnancy loss? Is defined simply as any abortion that occurs before 20 weeks of gestation or within the first trimester. Now, oftentimes the main symptoms that present as pregnancy loss is just vaginal bleeding and spotting. Physical examination will either show an open cervical os or a closed cervical os. I'll get to explaining that in a bit. Now, any pregnancy loss or abortion after 20 weeks of gestation is known as a stillbirth. Now, patients who have pregnancy loss after 20 weeks of birth, the treatment is usually natural. The woman usually gets contractions within 2 weeks post death of the fetus, naturally via labor, contractions, and ripening of the cervix. Now, moving on to this flowchart, first of all, we'll set this as a rule. All patients with any type of pregnancy loss will receive ROGAM except for complete abortion. Now, we'll start with the left side. If the cervical os is closed, this comes under two types of abortion. Now, we'll do a transvaginal ultrasound. If we see that the transvaginal ultrasound shows signs of fetal heartbeat or signs of life, this is viable pregnancy. Now, this is known as a threatened abortion. Why is it threatened? Because there's the threat of the fetus actually becoming non-viable. It's also known that threatened abortions, 50% of them continue on to be a viable normal pregnancy, and the other 50% actually progress to a spontaneous abortion. It can either be complete, incomplete, or inevitable. Now, as I said, transvaginal ultrasound shows viable fetus. This is known as threatened abortion. Now we'll look onto non-viable, as in no fetal heartbeat is detected. This is known as a missed abortion. Now we'll go on to the right side. If the cervical os is open and the patient has vaginal bleeding, this could only indicate a spontaneous abortion. Now, three types of abortion come under spontaneous abortion. First, we'll look at the first one on the left-hand side. If all of the fetal parts are inside the uterus and the fetus is non-viable, as in it's not alive, this is known as an inevitable abortion, because it's inevitable that all the fetal parts will be exposed naturally. Now, moving on, if some of the fetal parts are within the uterus and the patient is not, the fetus is not viable, this is known as incomplete abortion because it's not completed. There are still some parts left inside the uterus. And then finally, we go on to no parts of the fetus is inside, as in the uterus is found to be empty. This is known as a complete abortion. And for complete abortion, there's no treatment because there's no fetal remains within the uterus, and there's nothing we can do about that. So it's exposed naturally. Now, take it as a rule of thumb. All patients receive ROGAM. ROGAM is anti-D antibody used to prevent alloimmunization, which can cause RH incompatibility. Now, for missed abortion, inevitable abortion, incomplete abortion, and complete abortion, it only has one treatment. Okay. First thing we would do usually depends on the patient. Now, if the patient is less than 12 weeks of gestation, we would do an expectant management. We would just wait and see. We'd do serial beta HCG and transvaginal ultrasounds to see if the fetal parts have been evacuated naturally by the mother. Now, second option is medical management. We give mifepristone and misoprostol. What do these two drugs do? They cause cervical ripening. Okay, and we would also do serial beta HCG and ultrasound follow-ups. Now, last line, if medical management failed and expectant management failed, we would do a surgical evacuation through the procedure of dilation and curettage. Okay, now just take a picture of this flow chart and commit this to memory, please. Now, the only exception here is threatened abortion. As I said, 50% of threatened abortions progress to a spontaneous abortion where the fetus is not viable anymore, and the other 50% progress to a viable pregnancy. Now, this is a tricky situation. The only thing we can do right now is expectant management. We'd ask the mother to frequently follow up, and within these follow-ups, we'd do serial beta HCGs and ultrasounds, and would ask the mother to avoid strenuous exercise, and would monitor the situation from there. Now, this is the full topic of pregnancy loss and abortion. It's very summarized and it's very easy to understand. If you have any questions, let me know. Thank you.